Okay, cool. So, hi everybody. I'm happy to be here. I hope you guys are feeling okay. I'm Anita Amin. I'm a medical student, fourth year graduating this month, from Weill Cornell, in the United States in New York City. So I'm zooming in from there. And today we're going to talk about asthma. And I hope it's useful. I think if anyone wants to like raise their hand or type in the chat if they know anybody who like has asthma in their family or their friends or even has it, it's like a very common condition. I like have asthma and like a bunch of my friends and family do also. So hopefully we can just like go over kind of the basics on how to like what it is, how we spot it, how we treat it. And if you have any questions, feel free to type in the chat. And I'm so sorry if like I can't see it for some reason, but I'm gonna try and monitor it. So what is asthma? Does anybody know like what the most characteristic things about asthma are, how it presents, or even like a definition? I'll give y'all like a couple of seconds. I know we're Najra, I know you raised your hand. Did you want to answer?
Hello, mom. Hello to
Hi.
everyone. Yeah,
Hi.
uh, yes, asthma. Asthma is a chronic inflammatory disorder in the airway, and
Yeah.
and
Yeah.
it's
Oh my God.
reversible. Yes, yeah, it's reversible. And asthma characterized by decreasing shortness of breath, chest tightness, and cough. You can call that asthma.
Yeah, no, that's amazing, Najra. I was about to say like you basically read straight off what I was going to say in the slide. So, at its most basic level, it's like a reversible intermittent obstructive disease of the small airways. There's inflammation. There's this like hyper responsiveness and reactiveness. Importantly, it's like chronic. And but it is like people will have these like acute asthma attacks that can be so bad that they end up in the hospital, especially with kids. So it's a chronic process, but it can also have these episodes of like acute decompensations. And reversible is really important. We'll talk about that because you probably have a lecture on COPD, that is more of an irreversible process versus asthma is the kind of the reversible version of that. And it's also obstructive, which is different than more restrictive diseases like sarcoidosis. This is an obstructive process. So that's great. Okay, so our risk factors in epidemiology, it can present at any age, but it is like the most common chronic pediatric disease. And so, because we talk about it a lot in terms of kids, and that's when it gets diagnosed a lot of the time. One of the most important risk factors is atopy, and that's like the atopic dermatitis, like getting eczema and rashes from different like triggers, food allergies, and having like allergic rhinitis. And so those definitely put you at higher risk for asthma. You can also have a family history, smoking, obesity, and then also air pollution, low socioeconomic status, and poverty. Like in America, there's a lot of studies around like just the fact that people who live in like New York City or kids that grow up in like a lot of our cities are more likely to have asthma because of the air pollution, but also people are more likely to live in poverty in places where the air is not so good, and that can also put you at higher risk for asthma. So as far as the pathogenesis, I didn't want to go too into the details of this, but I wanted to just at a high level talk about the cells that are involved. So we have this like when you have a trigger, like allergies, for example, your body starts to mount this like response, and it involves mast cells that trigger a lot of like histamine, and that initiates this inflammatory cascade. So most common triggers can be allergies. It can be like an upper respiratory infection, cold air, and exercise also. And basically you can see in this picture, so you have like a normal airway, you have the lining, and you have these like smooth muscles that are usually relaxed. But then when it cascade starts, you start to get all this like gunk in the middle. It's like inflammatory cells. It's like mucus, edema, swelling. And you can see that this airway starts to narrow. And then on top of that, the smooth muscle starts to contract and become tightened. And over time will even like thicken and hypertrophy. And so that makes this even worse and closes the airway even smaller. And then you just get less airflow, and that's why it's very hard to breathe. And so that's the obstruction part. It's not like an obstruction. I used to think of it as like, oh, like, you know, like when a foreign body or something's like obstructing it. It's very similar, but it's like these airways are all tightening. And so there's less flow. And I just want to go a little bit more into the triggers, because I think this is important for basically like when your family member or friend or patient is coming up to you and like you're saying they're short of breath or their chest is tight. There's so many different diagnoses that fall into that. And so how do you know, like, is this asthma or not? Like a lot of it is related to the triggers, and you kind of have to take a good history and really understand like where they're going, what they're exposed to, and kind of do like a little detective work. And so in one category is just like, you know, the traditional allergies we talked about. So pollen, this is like, okay, I got this chest tightness every time I go outside when I'm in the springtime when there's like a lot of flowers, or every time I moved into a new apartment and there's like a lot of dust, for example. I get it every time I go to my friend's house because of their pets, their dogs or their cats. Also mold. Occupational asthma is really important. So also like flower dust can trigger asthma, like bleach, like a lot of different things that people are exposed to at work can trigger asthma. And they basically have chest tightness that resolves when they come home or resolves at the end of the day. But it's not actually the timing of the day, it's actually the fact that they're moving to a place where they no longer have that trigger. Oh, I see a question about atypy. Oh, so sorry about that. So atypy is just what we talked about here. So atypy is just this like triad of your body's like mounting a response to like allergic things. And so you can have like any of these, but atopic dermatitis is like eczema. You get like these itchy rashes on your body if you're exposed to like pollen or dust or any sort of trigger. You get the food allergies. Allergic rhinitis is like, you know, a runny nose that a lot of people get when they like are exposed to pollen or any sort of other trigger. And so if you have any of these things, collectively they're called atypy, but it puts you more at risk for asthma because it's a very similar process that your body is doing. Okay, I hope that answered your question. So then the second category is it's more intrinsic asthma. And very commonly in kids, they'll have this like viral respiratory illness, and then they'll have these like chest tightness or asthmatic symptoms and the wheezing. Cold air, we mentioned, laughter or like exercise-induced asthma. I've actually never seen a patient with the laughter-induced, and I hope not. That would be, you know, if you had to wheeze every time you laugh. But I've never actually seen that part, but I definitely think that exercise-induced asthma, I have that personally, and that can be kind of tough and can be a trigger. Oh, Shazia is saying I have seasonal allergies. Yeah, it definitely sucks. I'm a little sniffly right now because there's a lot of flowers in where I'm at. So it's definitely tough. And okay, so GERD can also exist at the same time as asthma, like the reflux that a lot of people get, and can kind of like I think the mechanism, it's kind of interesting. I think it's like the reflux can, like some of it can end up in your lungs, your respiratory tract, and irritate like your respiratory tract and trigger some of like the bronchospasms of asthma. But it's something to think about. Something that's less rare, but you should ask about is aspirin or NSAID medications, beta blockers. Some people can take these medications and it can trigger their asthma. Stress, and then we talked about like any sort of like these solvents, bleach, ozone. Tobacco smoke is a really important one. I put here just to call out like childhood exposure to secondhand smoke, like tobacco smoke, has definitely been shown to increase the risk of asthma. And I think that's part of why like some of the laws like that we have here to like make sure you don't like smoke inside is because like it can really like affect kids, and it makes them more likely to have asthma growing up if they have a family member or someone around them who's been smoking. So that's an important note. And then, okay, so I know, so you guys mentioned, I think Najma and someone in the chat mentioned kind of like what these symptoms are. So we'll just go over them quickly. Asthma, you have this like dry cough that it can worsen at night / early morning, and then worsen with the triggers. You get shortness of breath and this chest tightness. It's interesting. So how does stress cause asthma? That is such a good question. Oh my gosh. Yeah, I wonder if like, so with stress, like I think I can look that up, and I'll put my email also if you want to like email me that question later so I can give you a better response. But we'll talk about how like inhaled like corticosteroids, which basically like kind of decrease like the stress hormone and the effects of those in the body. Those are part of the treatment for asthma. And I wonder if like kind of this inflammation that stress causes in your body is more likely to trigger asthma, because that inflammation is part of the reason why like your lungs like kind of constrict a little bit. But that's just a guess. I actually don't know the mechanism for stress. How does exercise cause asthma? So I'm forgetting the exact like mechanism, but it's something about, so like when you exercise, your blood flow increases. You also get like more like adrenergic like receptor activation like with your beta ones, and I think those tend to like constrict your airways. But I forgot the exact receptor. I'm so sorry about that. If anybody else knows the answer to that, yeah, more demand for oxygen. I think that also makes sense. Like, I don't remember the exact mechanism. Sorry about that. Yeah, I think it's a lot of different things, but also the demand for oxygen makes sense too. Um, I think like I know that at night, like it's more likely to worsen at night because I don't think they know the mechanism for it, but with your circadian rhythm, when you go to sleep, like your airways do like narrow. And so people are more likely to have worse attacks at night. Yeah, exercise is like stress. Yeah, they're kind of very similar in terms of like what they activate, like that sympathetic response. Um, Yeah, so I don't know every of those mechanisms. I think it's really interesting to look up, and I'll look all those things up if anyone want to email me and talk about it. A physical exam, I think so. We learn these things for like tests, and I think so. You can you get your stethoscope, and you'll hear this like prolonged expiratory phase. So basically, like the exhale is longer. It takes like a longer part of like the breath, and you'll also hear these like wheezes. And if you percuss the lung and like tap, you might hear some hyperresonance. I think practically like that the teams I work with, like we don't really do the percussion, and you can sometimes hear the expiratory phase. I think the thing that helps us the most is the end expiratory wheezes. You can hear like they'll inhale and then they'll exhale, and at the very end of that exhale, you'll hear these like wheezes that sound kind of like musical trumpets at the end, and that can kind of help. And that's like the airways kind of like closing onto these like narrow kind of mucus plugged situations. Sonia saying I think it's not common just before something. Yeah. Okay. And then on the physical exam, if they're in like an acute asthma attack, you'll also see this like accessory muscle use and respiratory distress. They might be tachypnic, so they're breathing like a lot faster to get the air in. And I had a video, I found like a YouTube video of what this looks like. Let me know if it doesn't like play, but this is what it looks like. So you can kind of see, let me mute them, but I hope you guys can see this, but we call this belly breathing also. Oh, I don't know where they're going with this, but let's go back. You can call this belly breathing, but they're basically using these accessory muscles to breathe and like get oxygen into their body. And that is pretty like common in an asthma attack and an acute situation. So we got that. And then so as far as like, does anybody, let me pause and see if anybody has any questions. Yeah, I see people in the chat with, yeah, some great explanations about like stress and the immune system and sympathetic activation. Yeah, I think there's like a couple different answers that they all interact. Okay, so we're gonna kind of go into like diagnostics now. So let me see, how much time do we have? Okay, we're good on time. So the most, I think usually initially people are gonna get a chest X-ray because even if it seems like a pretty solidly like an asthma attack or sounds like asthma, you know, you want to have like a big differential and chest tightness, shortness of breath. Like these are really common for a lot of things like pneumonia, like heart attack. Like there's a, you know, there's a lot of different things. So we usually always get a chest X-ray, and it's pretty cheap too. So you get a chest X-ray. Does anybody know what's abnormal here?
I think pulmonary hilus, the lung hilus are dilated here.
Oh, you know, that's a good point. I think like in this image, maybe I picked an image that has that. Yeah. Yeah, I could kind of see how like there's some of that vascular, you can see the vasculature and maybe it's like a little congested here. You can see these lines a little bit more. That's a good point. But the other thing is, oh yeah, so Rosie is saying the diaphragm. Yeah. So basically, so this is kind of a trick question. Sorry, was someone saying something? I'm so sorry.
I guess because there is the black goes for the air. It shows air in an X-ray. So there is on the trachea and the side there is more whitish. So it means that there is no much air because of the bronchospasm, I guess.
Yeah, so are you saying like, oh, so you're saying there's more like air? So like there is air trapping. So so Dr. Amnagul, raise your hand. Do you want to speak? Go ahead.
Yes, doctor. It's mostly look like normal, but it shows some hyperinflation, like due to the trapping of the air, or due maybe it's taken during the inspiration. Therefore, it's showing little dot, which represent air in the lungs more. Thank you.
Yeah, exactly. That's perfect. Okay, I see a couple other people raise their hand. Go ahead and speak.
Ma'am, and here this just X-ray, and here's hyperdense. It is more black color due to trapped air. And the second thing, the trapped air pushed the diaphragm down, so the diameter of the lung has increased.
Yeah, no, these are all like really spot on. So basically what's happening is, so on the right, it says, you know, maybe normal. So like a lot of times you get the chest X-ray and it all looks normal, even though they have asthma, or they might even have chronic asthma. But one thing that you might see is what y'all said is hyperinflation. The diaphragm basically is flat. And I kind of, the easiest way to kind of see this is, I think the rule is about 8 ribs, but you can count down. So you count 1, 2, 3, 4, 5, 6, 7, 8. And like the diaphragm is usually kind of like up closer to here. And if it's flatter and it's down here, it means the lungs kind of expanded. And the hyperinflation is, like you said, like the air is being trapped there because the lungs are having an issue like breathing that back out. And so over time, in a chronic or severe asthmatic, you'll see this inflation. Is it specific to asthma? No. you can see this in also the other obstructive diseases, chronic obstructive pulmonary disease, COPD, and smokers. So a lot of times someone will have smoking history, you can see this. But also somebody could have a COPD or asthma and you might not see it at all. So chest x-ray isn't always a great way to diagnose asthma. The gold standard we actually use is a pulmonary function testing, and this is how you make the diagnosis. And you can see they put them in like a chamber and make them breathe into this tube, and you measure kind of like how much they can exhale. I'm not going to go too deeply into each of these like specific ratios, but in general, you will see a decreased FEV1 and a decreased FEV1 over FVC ratio. But you can also see that in like other diseases like COPD. And so what actually makes this asthma versus COPD is the obstruction is reversible with a bronchodilator. So these things will like decrease, but then you'll give them like a treatment like albuterol, which we'll talk about, and all of these things will kind of resolve. And so so I even marked it in red because this is like a very important distinction, especially on tests, but in general, like asthma is a reversible condition for the most part, and then its close relative COPD is a more sort of permanent degradation and like more irreversible and won't respond as well to just giving them a bronchodilator. Yeah, and if we have time, I'm happy to kind of define a little bit more what these things are. But that is the gold standard on diagnosing asthma. I did want to mention, so one other thing that we do is with like if someone's having an acute exacerbation is get an arterial blood gas, and this can be, so this will basically at the beginning of an attack show mild hypoxia because they're not getting as much oxygen in, and you'll get like an early respiratory alkalosis due to the tachypnea. And so I don't know if you guys have gone over like acid base, but just a quick review. So with respiratory acid base status, like it's you can think about CO2 mainly, and CO2 is this like acidic, it pushes your body to be more acidic the more CO2 you have. And so if you're hyperventilating, you're breathing fast, you're breathing a lot of your CO2 out of your body. And so asthmatics in their attack, they're breathing a lot of CO2 off. You got less CO2. CO2 is acidic, so if you got less of it, you become a little bit alkalotic. So a lot of times you get an ABG when they come in, and you'll see this like early alkalosis. The issue, the important reason why I get the ABG is you might see if it starts to get severe, you might see a normalization. So CO2 will be kind of low and alkalotic, but it'll start to climb. And that basically should be like an alarm sign for you. And it'll even climb to the point where they become acidotic and their CO2 is like high because they're retaining it. And that should really be like an alarm signal for you to consider giving them BiPAP or some sort of, even intubating them. Because basically what's happening is, you saw that video with like the chest retractions, and they're like using their accessory muscles. And so those muscles start to like fatigue and tire out over time, especially in kids. They start to get tired. And so they basically stop like blowing off the CO2 and start retaining it. And so that's the CO2 starts to build up, and then they become acidotic. And it basically means that they no longer can like breathe on their own. Their muscles are too tired. They can't oxygenate on their own. So you have to think about like getting an intubation cart close by. And that's kind of the purpose of the ABG. You want to assess whether or not you need to know what their acid base status is for this reason. It's usually for more severe attacks. Yeah, so any questions on that? Those are some of our main like diagnostic tools. Okay, awesome. I just wanted to, before we go into like treatments, I wanted to talk about the differential diagnosis, because there's a lot of different things that can also look similar to asthma. Does anybody like have any ideas of like, I kind of mentioned some, But any other things that would be on your differential, if somebody comes in with like chest tightness, shortness of breath, and maybe it's like intermittent, like what other than asthma can cause those things? Yeah, pneumothorax, COPD, especially things you don't want to miss, you know, like you could die from a pneumothorax. COPD also very serious. What else could you die from that you like wouldn't, that might present? Allergic rhinitis, yeah, for sure. Bronchitis, emphysema. What about like somebody gets stung by a bee or they have some sort of allergic trigger and then they start to like have a lot of trouble breathing? They might even swell up. Yeah, bronchiectasis is good. Emphysema. Yeah, this is great. Cystic fibrosis, GERD. Oh, this is awesome. Yeah, I didn't even, some of these I forgot to even put on. I got, okay, so we'll go through a couple. So one you want to think about is anaphylaxis. So anaphylaxis is basically like when you have like an allergic trigger. For a lot of people, it can be like a medication. Classic for a kid is like they get stung by a bee or they eat peanut butter and they don't know they have a peanut butter allergy. And then they start to like have trouble breathing. And also they can, you know, they can throw up, they have swollen mouth. You want to look for those other symptoms. So in some ways it can look similar to an asthma attack in the sense that like, it's kind of sudden, there's like some sort of allergic trigger maybe. But also like with an asthma attack, you wouldn't have all the swelling. You start to get swelling. Some people will get the swelling of anaphylaxis. And some people also like throw up, but you want to think about anaphylaxis because the treatment, does anybody know what the treatment for anaphylaxis is that you immediately have to give as soon as possible? Yeah, for sure. So that's exactly right. We call it an EpiPen in the US, but you want to get them some epinephrine as soon as possible. Yeah, and even if like you're at a restaurant or something and like you can't tell whether it's like anaphylaxis or maybe even asthma, like you should just give the epi if you have epi, like it can't hurt. So that's one thing you want to look out for. Another thing is, especially with kids, like the foreign object like lodged in the respiratory tract, they can get the same kind of wheezing, especially end expiratory wheezing. You get that too. And it can be kind of like an acute thing even. Generally, I mean, sometimes kids can be kind of sneaky about this. So you might not even have history or a parent seeing that they ate it, just started happening. So you might not know. And then you would generally, hopefully see a foreign object on the chest x-ray. The other thing, so this is actually an important thing. I actually like have told, diagnosed a couple of my friends with this during pollen season right now. So postnasal drip, it presents with like this, you can have like some of the like cough of like asthma, but you have like all this throat clearing, basically a normal otherwise exam. And basically, sorry, I'm just trying to read the chat as well. So basically like postnasal drip, it's like allergy related. You have like allergic rhinitis and the like, I guess the mucus and the like the fluid that's like being produced in your like nasopharynx drips down and like starts to irritate like lower in your respiratory tract. And so like that can cause this like irritation, some of this cough, and it also is triggered by the same things that asthma is triggered by. The difference is like you don't get this wheezing, like it doesn't go all the way down. It's like very upper respiratory. It's not like all the way down into your lower airways. So like your pulmonary exam is going to be normal. And this is also like will be you just treat with what you treat allergies with. So first generation antihistamines, you can give them Benadryl, like diphenhydramine, fexofenadine, like cetirizine, loratadine, like anything that people use for seasonal allergies. will help with postnasal drip. And that's one of the easiest ways to like kind of know that it's postnasal drip is you give it to them and it resolves and it's fine. Asthma will not respond to those things. So congestive heart failure is one. I think it's a little bit harder to, it's listed on the differential, but it's much easier to see like in an older person, they have this like volume overload and that it's not asthma. But if it's like a very insidious like volume overload picture, this person hasn't been like followed for a very long time, like it can present similarly in terms of the cough, like this intermittent cough. But with the shortness of breath and cough of heart failure, you'll see that like it gets worse, like when they're lying down, for example, on exertion with exercise, and those things can happen with asthma too. So you kind of want to like look out for this. Then GERD we talked about. Okay, any questions? Otherwise, we can kind of talk about the treatments for asthma. Okay, cool. Oh yeah, Najma, do you want to speak? Good.
Okay, treatment for asthma is that they have a different step for asthma. The first step for the patient who is addicted to asthma, we can use the short-acting beta agonist. Can give him for the patient, and again instead of short-acting beta agonist, we can give for the patient of asthma ICS, and also we can long-acting beta agonist given for the patient in the asthma.
Yeah, that's amazing. I also see Frida in the chat. Also added that. So y'all already got this. So I have some pictures of what the inhalers look like, but I grouped the two mainstays of the treatment into one like beta agonist. And so that's the first group. So the beta 2 agonists, basically we have the adrenergic beta 2 receptors, and they're in the like, if you remember that photo from the first slide, like how the smooth muscle is kind of the outside, that lining, they're in that smooth muscle layer. And normally these receptors, when activated, will relax that smooth muscle and then open up that airway. And so the agonists are just increasing that process. And so that's how they work. Yeah, so, so you guys already got it. So the examples are albuterol, is also formoterol, salmeterol. I'm not pronouncing that one correctly, but there's the short-acting ones, and then there's the long-acting ones. So the SABAs and the LABAs. The second group is the inhaled corticosteroid, which you guys have also mentioned in the chat. And these are targeting glucocorticoid receptors, and these are acting at like a gene level. So they basically are, they're binding to the receptor, translocating to the cell, switching on anti-inflammatory genes and switching off inflammatory genes. And so the overall effect is this decrease in those mast cells, cytokine release, decrease in a lot of the inflammation, all that like edema and mucus and all the cells that are like crowding the airway. And so that's why we use the beta agonists to like target the muscle lining. We use the corticosteroids to deal with kind of the inside of that airway, like all the stuff that's like gunking up the lung. And then together, these can be really powerful. Oh yeah, Najwa's also like glucotrione modifiers, C-corticosteroids, yeah, lutrin modulator, anticholinergics. Yeah, so there's a lot of different other medications. I didn't know how much to include right now because we could have an entire lecture on just all the different medications, but these are the two main buckets. Budesonide and fluticasone are common corticosteroids that we use. Oh yeah, so Noor, I'm so sorry if I mispronounce any of your names, but I see your comment about tachycardia. So we're just about to talk about that. So does anybody know like what the side effects of albuterol and like these inhaled beta 2 agonists are? Like what's one of the common ones that we see? Nor might have already mentioned it, but
It can be bradycardy.
What'd you say? Sorry.
Bradycardy.
So actually tachycardia. But yeah, you're totally right. So like the beta 2 receptors also exist in the heart. And so when you give albuterol, a lot of these patients will get a little tachycardic. But to answer your question, whether or not it's indicated or not, so I mean, in the hospital, we've given, it depends on how tachycardic they are, and what's actually threatening their life. Like, we've had kids who are tachycardic because they're stressed and they're scared, and the body's under stress, and we'll still give like the albuterol because otherwise they can't breathe, and so you kind of have to weigh that. Because it's not likely, that they'll die from like moderate, like a very small amount of tachycardia, but they could die from not being able to breathe. And so in general, you can give, like, at least in the experience that I've had in the hospital, we give the albuterol. And yeah, it does make them tachycardic. And you just want to know that, like, because tachycardia can also be a sign of like infection or something else going on in the body. And so you just want to, like, if you see a patient who's tachycardic, he's gotten albuterol, you can know that like that might be part of the reason. Let me see the chat. So tachycardia, yeah, headache, tremor. Yeah, it's like people would feel kind of like anxious. Yeah, and like hypertensive. So yeah, so that's great. And then with inhaled corticosteroids, I mean, corticosteroids have a lot of different side effects, but does anyone want to, there is one that's like kind of testable, they kind of test you on. Does anyone, I'm just kind of gonna read my mind question, but does anyone know the side effects of like inhaled corticosteroids? And it's kind of like why they say like when you inhale, like make sure you kind of like drink something or like take a drink of something or wash out your mouth afterwards. Yeah, there's also omalizumab, the monoclonal antibodies for really chronic severe. Yeah, so fractures and immunosuppression are definitely things that are associated, especially with like the IV or like oral, like in your blood system. Oh yeah, so Nora definitely, yeah, oral candidiasis. That's exactly what I was looking for. So one of the ones with inhaled corticosteroids, because it's mainly it's mainly accessing like your respiratory tract, is that risk for infection. Yeah, so that's why they kind of recommend for you to like drink something or try and clear out your kind of like your oral, area, like after you inhale these, because there is like an increased risk for candida. Yeah, okay. So any questions? Otherwise, I kind of want to go over just the last points on treatment. I have a video so I just wanted to quickly go over like with an acute exacerbation, like in the field or a restaurant, if you see somebody like, you basically want to like sit them upright and call for emergency help. Like most people, it's not going to be the first time they've ever had an attack. But let me see. So I just think this video kind of does it well. So if they're unconscious, you would go through your ABCs, but if they're conscious, then you basically sit them upright and then call for help. And then usually they have an inhaler. You're supposed to shake it like 10 times maybe. And then you will give them, I mean, you can give them one puff. 2 is fine. It's really whatever they're prescribed, but it's an emergency situation. Give them 1 or 2. And then you kind of have to wait for help. And it kind of depends. They give very specific minute amounts for this, but you can wait like a certain amount of time, like 3, 4, 5 minutes, and then give them another puff if the first couple really didn't help. And so that's just a quick summary of like acute. And then they should be on their way to the hospital after that. For chronic, asthma. So you guys have already kind of mentioned this, that it's like called step up. We have a stepwise approach to chronic asthma medication. So all patients, after they've been diagnosed with asthma, should be on a short-acting beta-2 agonist as needed or standing. And this is like albuterol. And so the stepwise approach is based on classification. Wait, let me exit out and go to this slide. So classification, I guess you can memorize this. It's up to you. I don't know that we're very much tested on this, but I think it's good to know just the range of the classification. So intermittent basically means like less than 2 days per week or less than 2 nights a month. They have like their chest tightness or shortness of breath or whatever it is. And that's the lowest. But it can go all the way to continual daytime or frequent nighttime symptoms, and that's the highest level. So with that, with intermittent, you would start them on albuterol as needed, for example. If it gets to mild persistent, it gets worse, then you would have the SABA, which is albuterol, and you would add a low dose inhaled corticosteroid. So they'd be taking 2 those. And then with moderate persistent, you would add a third medication. So you can give them a long-acting beta-2 agonist like salmeterol. And a lot of companies actually will like combine these medications into one inhaler. So they're not carrying around like 3 different medications. And then, or you can just give them like an inhaled medium dose corticosteroid. And then for severe persistent, you can give them like a LABA, which is a long-acting beta-2 agonist, and a medium to high dose corticosteroid. So it's stepwise based off how bad the symptoms are. Here's the classification again. And I think the last thing I wanted to mention is just this asthma action plan. I think it's something that's a lot more common now that we give, especially to kids, and it's something to think about for parents and talk through. Like the first half of it is just listing the medication so they know how often they should be taking it. And this, it seems kind of obvious, but it's so important to like have this for them, because if somebody's like, especially kids, like if they're supposed to be taking it 2 times a day and then they don't take it, and then they go run out in the cold air and exercise or like play soccer, it's very easy for them to just go into like an asthma attack and then end up in the hospital. And like that can be like a really scary, hard thing on the body. And so we really want to prevent that from happening. So this helps. And then I think especially this, like going over this with your patients or anybody you know like who has asthma, having like the green zone that they feel good, and that's when you take your prescribed medications before you exercise or before you are like about to go to a place or a situation where you think you're going to be triggered. Take 1 puff of albuterol, and then avoid things, know your triggers. And then the yellow zone is you start to feel some of the classic symptoms that you usually feel. If that happens and you take XYZ, you increase, like maybe in the green zone you take 1 puff, and the yellow zone you take 2, and then you call for help, or loop somebody in that you're in the yellow zone. The red zone is basically a 911. Well, in America we have 911, but you basically need to get to the hospital and like ask for help. And maybe this is like take like 4 or 5, an increased dose of whatever medication you have if you have it. And so yeah, those are the main things to like kind of educate your patients on. And that's all I had. Is there any questions? Anything we want to talk about?